Good afternoon. My name's Rich McKeon. Welcome to the bite-sized bit, the fast break of webinars. We're grateful to welcome you here on behalf of the Global Value-Based Healthcare Symposium, which is scheduled to be held here on the David Eccles School of Business grounds on May 11th through 13th of 2021. We're grateful for our co-hosts, the Eccles School of Business and the Green Templeton College at University of Oxford. We also are grateful for our co-sponsors, Select Health, Intermountain Healthcare, J.P. Morgan, and Levitt Partners. Now, today we have the unique opportunity to be edified by Brent James. Many of you know Dr. James, who is known internationally for his work in clinical quality improvement, patient safety, and the infrastructure that underlies successful improvement areas, such as culture change, data systems, payment methods, and management roles. He's a member of the National Academy of Medicine and participated in that organization's seminal works on quality and patient safety. He's a clinical professor at the Clinical Excellence Research Center, the Department of Medicine, Stanford University School of Medicine, and that is only among many, many other things. We're grateful for his participation. Brent?
Thanks for being with us. My purpose today is to make the case that pay for value is alive, well, and growing. It's in your future, whether you know it or not. To make that case, I'd like to go through 4 steps. Number 1, we need to talk about clinical variation, really quality failures. Number 2, we'll move that into the concept of waste in healthcare delivery, estimate its size. Number 3, it turns out that waste relates directly to payment mechanisms. This is going to be the primary argument about why pay for value is so critically important. And finally, number 4, I track a series of what I call forward-looking indicators that show that pay for value is actively growing and is our future. Well, number 1, clinical variation. Way back in 2009, I was asked to testify 4 times to various congressional committees. It was a run-up to the Affordable Care Act, the ACA, twice to Senate Finance, the Committee of Record for Health Policy in the United States. I was trying to devise a way to reduce a truly huge medical literature to an understandable form. If you did a Medline search on articles looking at variation in care delivery, you would roll out more than 40,000 articles in peer-reviewed journals. Amazingly consistent in results as well. Well, this is a breakdown that I used. 4 main areas. Number 1, people like Jack Wenberg at Dartmouth measuring geographic variation in care delivery, dramatic differences from place to place. I think we were the first group to show that that variation extended down into single hospitals, single clinics. In fact, the level of variation within a hospital or clinic was larger than the geographic variation that Jack and others were showing. Variation in physician practices were large, nursing practices were similar. The highest amount of variation I've ever measured in my career is physical therapy. So it's not just physicians, it's endemic across all of the healing professions. The problem? Well, number 1, the care is so variable, it's pretty much physically impossible that all patients, even with gold card access, could be getting good care. Number 2, it was associated with waste. Now, the geographic variation led to item number 2. It was really Bob Brooks or Rand who led the initial effort. He said, maybe we can explain variation in care through something they labeled inappropriate care. Care was judged inappropriate if the risk inherent in the treatment outweighed any potential benefit to the patient. This in professions that hold as our primary maxim, first do no harm. There used to be areas where we put patients actively in harm's way. They developed formal tools for assessing that. 2 major findings from that body of research. The first, it turns out that inappropriate care does not explain geographic variation. A community that had very low utilization rates for a particular treatment compared to a community that had very high utilization rates, about the same amount of inappropriate care, but a secondary, totally unexpected finding. The high watermark in that first set of studies was carotid endarterectomy. 32% of all cases performed judged to be clinically inappropriate. The risk outweighed any potential benefit. Should never have been undertaken, but it was. It gets worse. The COURAGE trial in cardiovascular medicine suggested that over half of all cardiac stenting for heart attacks clinically inappropriate, very controversial among cardiologists, as you might expect. More recently, Gary Kaplan runs Virginia Mason Hospital in Seattle. He's a center of excellence for Pacific Business Group on Health. His largest customer is Walmart. One of the major surgeries he performs on behalf of those groups is back surgery for low back pain. Well, his first step is to establish clinical appropriateness when a patient comes to him. Now remember, these are patients who have been tracked to surgery in their home communities before they're flown to Seattle for the actual surgery. Gary currently turns back 52% of all cases. What he's saying is that over half of all back surgery in the country is clinically inappropriate. Number 3, November 30th, 1999, long time ago, Institute of Medicine's Committee on Quality of Healthcare in America publishes a report called To Err Is Human. You're familiar with it. We'd done an evidence review. We'd found about 60 major studies documenting an unfortunate fact. We estimated that between 44,000 and 98,000 people die each year where their cause of death in hospital was not their underlying disease, but the treatments we'd use to address those diseases, in a way that for each case, 2 independent physician reviewers had agreed the death was avoidable. It was not an unavoidable death. We knew we were being conservative. The best research since conservatively estimates about 210,000 preventable deaths per year. Now this one's kind of fun, kind of has karmic balance. The idea of a hospital is a major public health problem. Turns out that preventable injuries and deaths in hospitals mean that hospitals are between the 2nd and 4th most common cause of preventable death in the United States. A twist on number 3 leads to number 4. The person who really did most of the research work was Beth McGlynn at Rand. It turns out we have a number of things that we know for a fact work. Strong randomized controlled trial evidence of benefit. They tend to be non-controversial. Everybody within the healing professions agrees, yeah, we ought to do that. Big benefits. Beth identified about 90 such factors, tracked them carefully. What she showed was that for adults, we managed to do it correctly 54.9% of the time. For children, 46% of the time. 2 major articles in New England Journal of Medicine. Well, wait a minute. It's fairly easy to make the case that we routinely achieve miracles for people who seek our help in healthcare delivery. If we can achieve miracles doing it correctly half the time, what kind of miracles could we achieve if we did it correctly all the time? Or at least somewhere close to all the time. It means we're leaving a lot of lives and pain and suffering on the table. Now, all of these areas are directly associated with waste. An Institute of Medicine committee in 2010, we called the experts together, reviewed the evidence, and concluded our soundbite final statement: a minimum of 30% and probably over 50% of all money spent on healthcare delivery is quality-associated waste. This has a unique implication. The way that you eliminate the waste is to improve your clinical outcomes. You're not forced to trade off people's lives to save money. In fact, they both go together in the same direction. Truth in advertising, when I model it, models that I'm going to show you shortly, I get about 65% waste. Well, 65% waste. This year, the United States is going to spend about $3.6 trillion, with a T, dollars on healthcare delivery. That suggests somewhere on the order of $2 trillion a year in waste-based opportunity. The key thing to take away from this, the pot of money involved in quality-associated waste dramatically overshadows any other opportunity in healthcare. Oh, wait a minute. Not in terms of our mission, not in terms of our ethics of good patient care, just in terms of the money. It's at least 10 to 100 times bigger than any other financial opportunity in healthcare. It goes a level beyond that. It turns out quality is not free. It always requires an investment, change leadership, studies and investigation, data systems, sometimes changes to physical plant. It's just that that investment has a truly massive return on investment. So think of it this way. The traditional way that we've maintained revenues in healthcare delivery is to increase the number of billable events. Do more lab, do more imaging, recruit that heart doctor, build the new cancer center, deliver more care. you see. When we've done that in the past, our contribution to margin, how much does that actually give us on the bottom line? 5 to 9% is considered a massive success. The trick is if I were to take the same money and invest it in waste elimination through better outcomes, well, I can show examples, a minimum of a 50% contribution to margin. The one I'd really like to show you, about a 500% contribution to margin. It's not just that the pot of money in play is 10 to 100 times larger. The return on investment for change is similarly about 10 to 100 times larger from a purely financial perspective. Well, that leads us to formal waste models. This is the model that I use to make waste make sense. It's all based around clinical opportunities, clinical variation really. A 3-part model they stack. This allows me to make accurate estimates of the total waste in the system, taking into account interactions. There's another reason that it's so important though as well. It directly interacts with payment. This is an article that we published in Harvard Business Review 3 years ago. The 3 levels of waste shown in the previous slide interact with fee-for-service, per case, or DRG payment. And then finally, something I've labeled provider at risk. Provider at risk is some sort of shared savings. There are 7 or 8 different versions of it. But whereas you make the investment in care, the savings come back to the person who had to actually expend the funds. It all has to do with financial alignment. When we talk about investment in change to eliminate waste through better care, the group who always has to invest is the care delivery group, 100% of the time. On this slide, a red down triangle means that the care delivery group made the investment, but all of the waste savings went back to a purchaser, very often damaging the financial outlook for the care delivery group going forward, even beyond the initial investment. A green up triangle means that the financials align, that the group who made the investment, the care delivery group, is able to harvest savings back to recoup that investment and perhaps have a little bit left over for the next project. Oh, you'll notice on the slide there's only one column that's entirely green. It's the far right, labeled provider at risk. You've just seen the entire financial argument for pay for value. It's where the finances align so that those who make the investment get at least part of the return to recoup the investment and to build a platform for a better future. Well, the key factor, who makes the investment, who gets the waste savings. Now, something you need to know in that regard, there are proven methods by which you can actually make this work under something as retrograde as a fee-for-service payment system, anticipating a day when the shift will come. That's a topic for another day, but a very useful strategic topic about how you shift into a pay-for-value environment, not cannonballing into the swimming pool in one giant jump, but a step at a time where it makes financial sense. Just to show you that it's real, this is one health system in Utah. Across a 4-year time period, these sorts of clinical improvements tied directly to financial performance, we took more than $688 million out of our costs of operations, about 13%. Well, 13%. I believe the total amount of waste in the system is about 65. Pretty good start. What it meant, though, is we were delivering dramatically higher quality services at a dramatically lower cost. This approach subsumes things like population health, like patient safety, like clinical variation, even efficiency down at the level of supply chain or administrative overhead, all tied together into a single strategic approach. The financial implications are overwhelming. The really good thing, though, the way that you succeed financially is by improving the care that you deliver to your patients. I often say we count our successes in lives, and that's literally true. In conjunction with this slide that I just showed about financial performance, we could document more than 2,000 lives per year. People who in the past would have died, who don't die today. And you understand, that mortality is just the tip of the iceberg. Dramatically bigger impact in terms of suffering averted, function restored. In that context, what does our future hold? I track a series of what I call forward-looking indicators to help me understand how the market's transitioning. Turns out they're very highly community specific. Many people tend to miss them, but I look at them nationwide. I travel a lot and I see many communities. It's amazing how far down the road some communities are on this transition. Well, 4 of them. Number 1 is the largest vertically aligned care delivery system in the United States, Kaiser Permanente. They already have the insurance plan tightly coupled to the care delivery. It's a classic pay-for-value model. As they eliminate waste, yeah, most of the money shows up on the insurance plan side, but it all comes to the same consolidated budget. Pat Cornia tells me that over the last 4 years, Kaiser Permanente has expanded from $70 billion per year in services to over $90 billion per year. They're showing dramatic growth, not from geographic expansion. This comes from outcompeting other care delivery groups in their own current markets. Number 2, Medicare. It started with Mike Leavitt in the Bush administration at HHS. They launched an initiative to shift Medicare payment to pay for value. A fascinating thing, President Obama wins the election. His Department of HHS continues the initiative. Even more impressive when President Trump occupies the White House. Alex Azar, the current Secretary of HHS, continues to push the same agenda. And it's shifting. This slide shows fee-for-service Medicare, the top blue line, compared to Medicare Advantage and ACOs, accountable care organizations, mostly in the commercial space today, according to the Leavitt Group. Medicare fee-for-service has fallen to less than half of its old size, under 50% of the total market, and continues to decline as pay-for-value strategies take over as a part of conscious federal health policy. Number 3 on the list, much of the care delivery in the United States is delivered through employers. Employers, as a benefit, supply health services to their employees and to their families. Those are called ERISA plans. ERISA is the federal legislation, the name of the law, that enables employers to deduct those expenses from their taxes, from their cost of doing business. Well, modern healthcare points out that currently about 11% of all large employers directly contract with care providers, cutting the insurance plan out of the middle. It's classic shared savings, another name for pay for value. Well, they're growing at double-digit rates. As more and more large employers shift in to this mode, they're deeply interested in better clinical outcomes and just as much in lower costs of care. They make it work for the care providers who have to make the investments in change. Shared savings is just another word for pay for value. The last is in some ways the most interesting. Who's the largest employer of primary care physicians in the United States of America? Oh, if you said Optum Healthcare, a wholly owned subsidiary of the large for-profit insurer, United Healthcare, you got that one right. It's pushing up on 40,000 practices. I've spent time with the senior clinical leadership at United Healthcare. It's purely a pay-for-value strategy. They believe that they can manage upstream care in a pay-for-value setting, taking waste mostly out of hospitals and put that money on their bottom line in the stock market. They've invested billions of dollars in that strategy and are vigorously pursuing it today. It's not just ERISA plans of that form, though. Other forms of payer-provider consolidation are taking place at a large scale. Denny Cortez, former chairman of Mayo, tracks circumstances where healthcare delivery groups have set up their own health plans. Classic example, the University of Pittsburgh Medical Center in Western Pennsylvania. Currently, their fully aligned health plan supplies over 40% of payment for all the care UPMC delivers. They're going against Allegheny Healthcare, a similar vertically aligned system in a head-to-head pay-for-value competition. Oh, the thing you need to know, when you model out the tipping point where you earn more just on the purely financial side from waste elimination than you lose from fee-for-service payment, about 25%. 40% UPMC is well past that tipping point and all in on the strategy. It's not just ownership, where United Healthcare owns primary care practices, or UPMC owns their own health plan. It's through partnership. For example, in Hawaii, the large nonprofit Blue Cross plan, HMSA, has partnered with the Queen's Health Systems and with Hawaii Pacific Health in exactly the same strategy. As I mentioned, I travel the country. I am sometimes shocked and amazed how far down the road some of these strategies are. Now, it is local. Healthcare is very, very local in that sense, but it's growing. If it hasn't come to your community yet, it will. It's just a matter of time. It's a financially dominant strategy. Just follow the money. Well, the real attraction, it's money that comes from better care. Remember, we count our successes in lives. What does the future hold? We're going to see increasing focus on waste elimination through move upstream strategies. It's where the money is. Dramatically bigger financial opportunity through better care. As part of that, care delivery organizations, through ownership or through partnership, are going to increasingly seek, I've labeled it capitated risk, but there are 7 or 8 forms of it. It's probably better to call it shared savings, another name for pay for value. The trouble is if you fail to follow this course as a care delivery group, especially care practices or hospitals in particular, you're going to become something called a price taker, where you compete purely on the basis of price against a very high quality standard and thin margins, difficult futures. Well, I've described a developing future. Where do you fit in that future? What role will you seek? What course will you lay? What future will you create? The really attractive part about this, it has to do with what's called the value equation. A simple fraction where the numerator is clinical outcomes and patient experience of care, but the denominator is cost of care. Quality-based waste elimination strategies, pay for value, affects both sides of that fraction in a positive direction at the same time. As your clinical experience goes up, your cost of operations go down, and value increases dramatically. Of course, you have to align the financial incentives so that those who make the investment, the care delivery groups, get sufficient return on that investment to make it a viable business strategy. Pay for value is your future.
Brent, thank you for that remarkable presentation. We're so grateful that you'd take the time to be with us. We thank too our co-hosts and co-sponsors, and I'd also like to announce that on August 6th at noon Mountain Daylight Time, we'll be privileged to hear from Governor Mike Leavitt, former governor of Utah, former administrator of the United States Environmental Protection Agency, and important to this conversation, former Secretary of Health and Human Services. We'll look forward to seeing you then. Thank you so much for being with us today.